However, when you start asking them to separate, who is, if you think about this, who's going to invite them home? Does the DA say, well, yes, Ken, you're doing well. I'm going to invite you over for dinner Friday night. So where do they actually start making that pro-social kinds of change? And therein lies some of the challenges that even if they are willing to change, where is the group that they're going to be able to change and move to? And that's really the importance of reentry, is being able to make that transition into a pro-social environment. And there's some unique programming going on. Actually, as I talked to somebody yesterday in Washington County, actually here in your own state, there's some really neat things going on where people are trying to work and get some things done along those lines. So we haven't been successful because we have not taken into account the personality. And a simple definition of personality is how you perceive the world. If you don't perceive the world as a place where you have to do something to support yourself, that if you run low on cash, you just go down to the convenience store and ask them to give you some, or if your TV breaks, you just go next door and take theirs. That's a whole different perceptual framework issue that most of us don't have, and the reason I know that is we're here today. We're not going to visit our clients. So here's an adult study, and when you look at this, alcohol and drug abuse, adult symptoms of antisocial personality disorder. Number one is alcohol and drug abuse for 90% of the clients. Now what's most interesting about this study, when you look up there, is what year do you think this study was done? When you look at this profile of an adult who been arrested, been participating in criminal justice, had numerous arrests, when do you think this study was done? Any guesses?
1957.
Close. 66. 40 years ago. We know a lot about these people. We've just never dealt with the issues that bring them to the party. In one sense, what we've done is we've built a lot of institutions, we've locked them up, and unfortunately, they didn't learn much, so they got out what they do. Did it again. Did it again. I had the privilege of teaching, as I said, to Judicial College. One of the judges I taught with, he and I co-authored a book called The Punishment Myth. And in it we discussed the research about punishment works, but it tends to work for normal, ordinary, responsible people. And therein lies part of the rub, is our clientele doesn't really fit that category when they're involved in this cycle of criminal activity, because that's not where they are. And what you find about most of the people, most of the time, we follow most of our major rules. Our clientele, on the other hand, don't see rules as important in their own lives. In fact, they think we're all fools for following the rules, that there's a better way to live, if you will. I had the privilege of presenting with Nora Volkoff, who is the current director of the National Institute of Drug Abuse in Boston a couple years ago. And when we started talking about, this was an epidemiological study done on substance abuse with some of our clientele, and what you notice up there is that last sentence: we need to treat the APD syndromes because that's what's precluded us from having a more significant effect on treatment outcomes for substance abuse. Therein lies part of the issue, is most substance abuse programs, not all, but most, tend to treat the axis 1 issue of substance abuse, and that works well for those who don't have personality disorders. However, most of our clientele, when you look at the literature, guess what? Ours have the personality disorder, so when we treat substance abuse as the axis 1 or depression or anxiety, that's all interesting, and that alleviates those symptoms, if you will, but it doesn't deal with the underlying issue that brought them to the party to begin with. And we look, fortunately or unfortunately, this is interesting statistics, this was the survey done in 0102, it's the latest data out, and what we see basically is actually a growth of about 0.5% of alcohol-dependent people in the country. There's no explanation for why that's occurring, but it is occurring. There's more alcohol-dependent people in the cohort born after 1950 than those born before. So what works? This is a list of studies. Effective therapeutic processes that systematically alter how inmates make decisions, how they think, show substantially beneficial changes seen in recidivism reduction and other behaviors. I handed a book out that I hope that you all get a chance to just thumb through on what works in corrections. It was written by Dr. Doris McKenzie who is the chair of criminology and a renowned researcher from the National Institute of Justice, who travels the world now doing research, wrote a book on what works in corrections. It's an update, a compendium, if you will, of all the research, of all the program models that had research behind them, looking at what do we know? What do we know for sure we can hang our hat on? So when we talk about dynamic needs, I was just, I came from a federal presentation a few weeks ago. I was presenting at the the first evidence-based practice meeting for the federal probation department, federal probation and parole. And one of the things they presented was the strongest correlation for committing new crime were those 4 variables at the top that they showed to the 300 directors and officers. APD is antisocial personality disorder, antisocial values, criminal peers, and low self-control were the 4 major behaviors that you need to target if you're going to reduce recidivism. The programs that they invited there, they invited 4 of us. I threw in 3 because it actually has some research behind it. Change Company, NCTI, Reasoning Rehabilitation, Thinking for Change, and us as a program model. Out of those, 3 of the 5 programs had no data behind them. And I think actually they were surprised because this was their first evidence-based review, and so they were giving everybody a chance to present, do you have any research to justify why we should continue using your programs? This basically was a question that was posed to us. So those 3 had no substantive data to suggest that they should be continued, albeit a lot of offices were using these models and frankly didn't know, that there was no data supporting it, because the buzzword in our field, if you will, now is cognitive behavioral programs. So basically, if I write a cookbook and call it a cognitive behavioral program, my point to you is hey, I've got a cognitive behavioral program, you should use this, because it's just like everything else. And what we're learning through research, not surprisingly, is it's not all things are equal. It's kind of like if you go to a doctor and you have a heart condition, hopefully you went to a cardiologist. You didn't go to a foot specialist. And so what we're learning is you need to go to the people who are using research to support the clientele with which you're trying to target and work with. So what is cognitive behavioral therapy, if you will? What is that about? So when you look up here, I threw this in because basically the therapeutic tool at the bottom is let's client explore conflicts and emotions. That's what I'll call typical counseling. Most of us trained in treatment are trained in those counseling techniques. Now, is that a part of what I'll call helping people resolve some of their own issues in life for norms? Yes. It's based on the theory that we all have some insight into changing our lives. However, when you get over to what our clients need, and cognitive behavioral models obviously work for a host of other diseases and illnesses. If you look at the literature, cognitive behavioral has actually been around for over 50 years. A lot of research done on depression, anxiety disorders. But when you look over here on cognitive behavioral, what the difference is, it's teaching problem-solving strategies. And the one thing we know about our offender clientele is their problem-solving strategies are not very sound. It's kind of like, how are you going to pay the rent this month? I think I'll go rob the guy down the street. Might there be another opportunity to find some way to solve that problem? In their mind, it's a very limited problem-solving repertoire, so they respond in the same habitual pattern that they've developed, which is always limited to their success rate. And if you remember nothing else I said this morning, I'll send you this if you need it. Programs that include cognitive components are more than twice as effective as programs that do not. So if you're able to create a success rate of, let's say, 10%, would you like to have 20? By adding in a cognitive component, and this is borne out through all of these researchers' reviews of literature, of meta-analysis, when you add in the proper cognitive models, you can actually double your success rate, because all of us have some success rate. Don't get me wrong, doing something is certainly better than doing nothing. Sometimes it makes some clientele worse, but you know, it helps some people too. Don Andrews in '94, when he talked about what are effective treatment approaches, their cognitive behavioral nature, uses printed program manuals, addresses criminal thinking and needs. Number 4 is really probably their most resounding message. There has been research validating that the model works on the population with which I'm going